This week on Empowering Midlife Wellness, I'm talking again about testosterone for women with a little more nuance about how we get it, how we dose it, how we know you're getting the right amount. You won't want to miss this one. Hi friends, and welcome to this week's episode. If you're just joining me, I'm Dr. Susan. I'm a board-certified gynecologist and certified menopause practitioner dedicated to taking care of women through perimenopause, menopause, and throughout later life so we can feel our best now and also optimize our health as we age. So periodically I talk about testosterone for women, and I'm going to circle back on that again today. There's always a little nuance or sort of other way that we can talk about it to make sure that we are the most educated that we can be. I was really excited to hear on Peter Attia's podcast very recently, a fantastic interview with Rachel Rubin. Please check that out and listen to it. This should be something that every woman listens to. Rachel is a fantastic urologist who specializes in sexual wellness, and she really did a fantastic job of talking about all of the issues to do with menopausal hormone therapy and sexual wellness. Now, we agree on 99.9% of things in the menopause world, and there's always a little bit of difference of opinion. And so one of the things she said made me realize that there are some differences in opinion regarding testosterone, so I will give you mine based on a lot of experience, and I really want you guys to listen to that interview because it was absolutely fantastic. So as I would just say most or all educated menopause practitioners, we're all in agreement that menopausal hormone therapy, that would include estradiol, progesterone, and testosterone, is not only safe, but beneficial, like markedly beneficial for the great majority of women with very, very few exceptions, especially if we start it early. And we have talked about that almost ad nauseum, but you can't say it enough. We need to start on menopausal hormone therapy early and almost everybody. But let's not forget about testosterone. So given that most people agree now, and thank goodness they do, that testosterone is beneficial for women. Now, many studies have shown that testosterone, given in the appropriate dose for women, improves sex drive, particularly in postmenopausal women. And this is well understood and well accepted. But what's questionable, I guess, and some people have differences of opinion, is how to deliver it. There are choices on how to get it into your system. So assuming that we all agree that it is good to get it into our system, testosterone not only helps sex drive, that's been the most studied measure point, so we call it HSDD, hypoactive sexual desire disorder. You and I might call that sex drive. Also has been shown to help bone health, muscle health, energy, optimism, moods, urethral bladder health, lots of things. So it's beneficial in many, many ways. Now, people often think, oh, the downside must be masculinizing symptoms, hair growth, acne, hair loss, clitoral enlargement, voice deepening. No, not if the dose is kept within what's called physiologic range for women. So going back to what I've said many times, the dose is the poison, not the testosterone. So anything given at doses too high will cause problems, whether it's alcohol, Tylenol, sugar, testosterone, anything. So we want to make sure, of course, the dose needs to be given appropriately for women. Now, testosterone doesn't follow the same pattern that estradiol and progesterone do. We see an abrupt drop-off of both of those two hormones. Estradiol and progesterone go from high to zero at the time of menopause, but testosterone follows more of a slow downhill slope, highest around age 25 or 30, and then for almost everyone, slowly declining. It can reach levels that are undetectable in our 40s or even earlier. Mine was 0 or undetectable when I was 45. Other women still produce a little bit from their ovaries or even their adrenal glands, but for almost everybody, it's much lower than we were younger. Now, along with that, just like for men, many women experience a drop in sex drive, energy. It contributes to muscle loss, bone loss. A lot of things can be improved with testosterone, not to mention bladder and urethral function that Dr. Rubin touched on so importantly. So this is really important. Now, there's no right or wrong way to deliver testosterone. I'll just say all of these are good. and they depend basically on your preference, because lifestyle and your particular preference is really important. So let's just say we all agree that it's a good idea to take testosterone as women, and that might be a leap for you, but I'm going to put a link to some previous videos that I've made that might get you up to speed so that we can all be in agreement with that statement. Let's just say we're in agreement that testosterone is a good idea for women, especially in postmenopause. Then the question is, okay, well, how should I get it? Like, what form should I get it in? Well, one recommendation is, because men have lots of different FDA-approved testosterone products, we don't have any, you could get a male testosterone product and use 1/10 of the dose. And that sounds like a great idea, and it's a great idea for sure. Now, the downside of that idea is that practically it's quite difficult. Here's point number one. If I write you a prescription for male testosterone gel, it will not be covered by insurance because you're not a male, so you'll be paying for it, number one. Secondly, you've got to divide this into 10 somehow. Now, you can do it, and Dr. Rubin was suggesting in her patients, she uses a great method where she prescribes a particular testosterone gel, and then the patient uses a little syringe to get out what she called a blob. A pea, a blob, a bit, right? It's not precise because you can't divide something in 10 precisely, but that's really okay. There's nothing wrong with that. Nothing wrong with that. I'll just say I've tried it. It wasn't my favorite for a few reasons. First of all, if I go to the pharmacy, or if you go to the pharmacy, there's some raised eyebrows and things. I've had patients leave the pharmacy crying because the pharmacist said, "Why did they give you this? Your doctor's doing the wrong thing. You're not a man. This is a bad idea. Are you transgender? What's going on here?" There's just a lot of misunderstanding. So I've sort of joked to my patients, if we give you this, go through the drive-through with dark glasses on, or send your housekeeper or your daughter to pick it up. Don't go yourself. I'm sort of joking, but I mean, they just make it difficult. Then you do have to pay for it. Depending on the product, it may or may not be particularly expensive. But okay, now you've got it, and you've got to use a syringe and try to figure out how to get a blob of that out, and then you can put it on your cuff, rub it in, as Dr. Rubin suggested. That's great. Then you have to wash your hands. Personally, I like to put it on my inner arms, rub my arms together, that way you don't have to wash your hands. Doesn't much matter. Put it on somewhere where you have thin skin and it's easily absorbed, and that's great. Now, you do have to use it every single day. I actually like to divide it up twice a day because that eliminates the highs and lows over time. It gets much more steady. So if you're using a gel at least once a day or even twice a day, it's hard. I've tried it. Now, I work out a lot, I swim. Recommendations would be not to sweat or exercise 30 minutes after, put it on clean, dry skin. It just gets tricky. I'll tell you what, I'll forget to do it. I'll go to work and I can't remember, did I do it or did I not? I'll leave it at home when I travel, and I travel a lot. Now, you might not be like me. You might be very good at remembering to do it, and that's not a problem. So that could be a great option for you. Now, other people, like me, it was not happening. I was not getting great results because of user error. I just wasn't doing it because I found doing that every day or twice a day was just difficult. So depending on the person, that could be harder or easier. Now, I mentioned that we don't have an FDA-approved testosterone for women. So we're using testosterone off-label if we're using the male stuff, right? And that's just totally fine. However, you can get compounded testosterone from a very reputable compounding pharmacy that might be a little bit easier to use, possibly, depending on your compounding pharmacy. The one I use comes in a little pump, and it's in the dose that's already measured for women, so you don't have to divide it into 10. You just push the button and rub your arms together, and that's that. Well, some people might say, well, that's not an FDA-approved product. I think that's splitting hairs. Honestly, a great compounding pharmacy is going to make very high-quality testosterone. Actually, even though that's an FDA product that the men are getting from the pharmacy, so yes, maybe it's well monitored and so on, we're not getting a precise amount. Nobody disagrees with that. It's certainly not precise to get a blob or try to do 1/10. So the idea that getting the male product is more precise or accurate than a compounded product, I think, is not accurate. It's just different ways of getting the same thing. So either way, we're getting testosterone, and there's a little bit of variability either way. Let's just all accept that, whether we're getting the male stuff and trying to divide it by ton, or whether we're getting it from a very reputable compounding pharmacy. And honestly, there's not much cost difference, if any, because it's not going to be covered because you're not a man. Compounded testosterone might cost, say, $60 a month, something of that nature. So yes, it's a small expense, but overall, probably not a whole lot of difference there. So I would not say personally that it's better to get the FDA-approved male stuff and divide it by ton, because frankly, it's just practically quite difficult. Or the compounded, I just give the patient the option. So I think it's a really good idea. Any menopause specialist that you're seeing, they need to present you with a whole bunch of options and not just tell you this is the only way and this is what I do, but to give you all the options and the pros and cons. And then I tell my patients, like, this is one option, here's another option. What would work best for your lifestyle? And then you get to decide. Maybe your insurance is different, all the many, many variables, because everybody's different. And then how much do we get if we're using a gel or a cream? Well, the good news is that testosterone gel is approved for women by their government agency in Australia. So that's a very civilized country. Arguably, they're more advanced than we are when it comes to menopause because they have approved testosterone. So they have a product, and I've shown pictures of it before. It's called Androfem. Their recommendation is to use 5 milligrams a day or 10 milligrams a day. So it's a blob or a bigger blob, right? Not particularly precise, but their approved product is arguably better regulated because it's approved by their government, and it comes in a tube and tells you how much to take. So 5 milligrams or 10 milligrams, that's a pretty huge difference. That, twice as much. The suggestion is use 5 milligrams for a while, and if you want to, go up to 10. I mean, that's the degree of precision that we're talking about. So when I use testosterone gel or cream, I actually start with half of that. That's just my preference, is to start low. So I start with 2.5 milligrams a day, increase to 2.5 milligrams twice a day, or we could do 1.25 milligrams twice a day. I mean, any of those are good solutions, and it would depend somewhat on where you're starting from. So for example, I saw a patient today who had a testosterone of 0 and a different one who had a testosterone of 25. You might want to take a little bit lower dose if you're already making some on your own. So we put all of these variables into the mix, and then we try it. Now, there is disagreement between different people about whether or not we should draw blood. Some people say never draw blood, just go by patient symptoms. Some people draw blood probably way too much. Some people use really expensive lab testing that is not necessary. But drawing blood at a common lab like Quest or LabCorp, they can check a testosterone level. And I do that just for curiosity. I'm curious to see what your level gets to. I also do want to make sure that it doesn't get significantly beyond what we call physiologic for women. So just say 50 to 100. Now that is not a number that's been presented in any study, but that's what we have found works for us and how many tens of thousands of patients, to keep it somewhere in that 50 to 100 range for the most part, knowing that it fluctuates a bit. So on average, somewhere keeping it in there, and that will improve sex drive. If testosterone is going to improve sex drive, it will do it in that range. It's not dangerous. At those levels, we don't see oily skin, acne, hair growth, all of those type of things. Now, if it's significantly higher, different providers, in my opinion, are giving way too much, and patients are being given enough to get to blood levels of 250 or more, which is on the low end of what men have. That's too much. I mean, you will see symptoms at those levels. So that's why I like to draw blood. One, for curiosity. Number 2, patients like to see the number. Number 3, probably most important, is make sure it doesn't get too high, because everybody absorbs things differently. In fact, in the studies done on testosterone, they did not draw blood. They used a very low dose. Low dose might be different in different people's opinion, but generally the idea is we want to keep it within what's possible for women, right? We're not trying to get to what's called supraphysiologic levels that never exist in nature. We're just trying to boost it back to sort of the higher end of where it might have been when you were younger. And that's where we see improvement. Now, because studies didn't measure blood, they just asked patients how they felt. We don't really know what numbers are perfect, or there isn't a perfect number. So some people say, well, just go by patient symptoms. So if you use this stuff for a while and your sex drive gets better, great. Well, then we're on the right dose and you're not having side effects, so therefore it's not too high. That's perfectly fine. I personally do like to draw blood for the reasons that I mentioned. It makes me feel better. I know that I'm not overshooting, and it helps the patient to feel better that she's not getting into trouble where she might develop side effects. So I think it has a place. Now, I don't know why this continues to be a problem, but the one thing that people love to disagree about is hormone pellets. And I've talked about this lots of times. I personally use a hormone pellet in my own body because the gel I just talked about, I swim, I work out all the time, I forgot. It was too hard and I didn't do it, and so I didn't get the benefit. A low dose pellet, and I'll tell you how we dose it. We have a very useful and proven delivery measurement method, so we know how to dose it properly in our practice. I just checked this morning, we've done over 13,000 pellets in my practice since we started back in 2020. Currently do about 350 pellets a month. Now, we are not a pellet mill. We probably 75% of our patients do not do pellets, but we offer it to patients as an option, and many of them choose it for the reasons that I did, because it's easier for some people. So when Dr. Rubin was talking about pellets, she had this opinion, and I respect her immensely, but this is a common opinion that hormone pellets are not a good idea because it gets to super physiologic levels. Well, that is only true if you get too much. Like anything, you can get the level too high. So I want to just remind you that you can do any dose you want in a pellet, and in my practice, we dose such that the testosterone level a few weeks later is in that 50 to 100 range, and that's in nanograms per deciliter. So we know it's very safe. In fact, if you're using a cream or a gel and you're not measuring blood levels, arguably, who knows where it is. So in my practice, if you're using a very low dose pellet, we kind of know more than the patients that are using cream or gel. We make absolutely sure that it doesn't get too high, and we dose very differently than perhaps the common practice that uses pellets, because absolutely right, they often use way too much. So it's not pellets that are the problem, it's the dosing that's the problem. Going back to the dose is the poison, not the medicine. We all know testosterone's great, so it's just not true that it's the delivery method that's the problem. How could it be? It's not the delivery method, it's the dose. So here's how I dose pellets. I get your weight in kilos, so just for example, I'm 55 kilos, and we give 1 milligram per kilogram. That's where we start. That is a very low dose. So for me, that would be, we round down, that would be a 50 milligram pellet, and that lasts for about 12 weeks. Now, when I do that, my blood levels are just where I want them to be. And I'm not the only person, because like I said, we've done 13,000 pellets, and we've got this pretty well figured out. Well, why is it dosed by weight? Well, when you start doing something that no one else has done before, you experiment. And so we've found that larger women need more, smaller women need less, kind of makes sense. So dosing it by weight made sense. And we've just found over time, again, we're doing 300 pellets a month, that 1 milligram per kilogram almost always gets into that correct range when we draw blood, and then patients feel better more than placebo. Now, does everyone feel better? No, because not everybody's libido problem is related to testosterone. In fact, if you come in and your testosterone's already over 50, I'm not going to give you any because you don't have low testosterone. So we have to just use our common sense. But we do not want our testosterone to be 200. So I totally agree with Dr. Rubin that most providers dose pellets inappropriately because that's how that particular arm was originally taught. But there is a really good, safe way to dose pellets appropriately so that we'll get into that physiologic range. And why would we want to do that? Well, because I don't have to do the gel every day. I don't have to measure the stuff and do the blob and then rub it in and all the things. Now, there's nothing wrong with doing that. It's a perfectly great thing to do. And again, I support using testosterone in any form, but I do disagree that pellets are bad, period. They're bad if they're given in the wrong dose, but so would cream or gel be bad if it was given in the wrong dose. You could give a patient the same dose that a male would take, and she would have horrendous symptoms if she used testosterone gel. Again, we want to use 1/10 of the male dose. Just the same, we want to use a very low dose pellet. and it gets, possibly more stable. I can't say that pellets give stable doses every day. Of course they don't. They go up pretty high the first 2 weeks and then stabilize and then drop off at about 3 months, and that differs for different patients. But just like the cream and the gel, it's not precise. I mean, we're talking about a blob of gel versus a very carefully measured pellet. Just to say, I think it's great to think through the things that we may have a bias against. Just like in the old days, people had a bias against menopausal hormone therapy altogether. So when these amazing spokeswomen, like Dr. Rubin, Mary Claire Haber, some of my other colleagues that are in this space, so correctly bring attention to the fact that we had this very strong bias against menopausal hormone therapy for years, and would say things like, it causes breast cancer, don't take it, it's dangerous. It was a bias, it was wrong, and we've been able to say, I was wrong about that. And that's a very important quality to have as a physician, to say, I was wrong about that. I've learned something new. I'm going to throw out there that some of these spokeswomen, they're amazing, I love them, thank goodness they're out there, I'm going to say are wrong about pellets. And to hopefully, if you're being taught the same way, if you've been taught to think that pellets are bad or terrible, because a lot of people say so, think about it. They're not bad or terrible. The dosing is often given in a bad or terrible way. I absolutely agree. But if the dosing is done appropriately, the hormone is the same. The dose is the poison, not the hormone. And you can get a pellet dosed correctly. I would suggest ask for 1 milligram per kilogram. That is going to be dramatically lower than what they're going to suggest that you get, most likely. But that will very likely get you into that safe range without those side effects. So this argument that you can't take it out, it's in there permanently, well, that's perfectly fine so long as you got the right dose, right? And if you get that 1 milligram per kilogram dose, you will not get too high. You won't. So we've done thousands of pellets, actually many, many thousands, and we don't see that happening in our practice since we developed that particular protocol. Now, sometimes it's not high enough. That happens. So if I put in a pellet and then I check it, say, 6 weeks later. Now, the reason to wait 6 weeks is, you do get a little bump initially, so we don't want to measure it right away. Very similar. If you drew your blood after using a gel or a cream, you don't want to draw it an hour after you put it on because it's going to look a little higher than it does most of the time. So if I'm measuring blood work in a patient who's using a cream or a gel, I will measure it somewhere in the middle of the last 2 doses. So if she uses it morning and night, we'll check it around midday. If she uses it once a day, we'll check it at the opposite end of the day. Point being, you want to check it in the middle, not right after or right before the next dose, because it fluctuates a little bit. So that's just common sense. That is not unique to pellets. So it goes up a tiny bit and then it stabilizes and then it drops. So 6 weeks is kind of in the middle of the stable period. That's a good time to check it. Now, if we check it and we've done 1 milligram per kilogram and it's still, make up a number, 30 to 40, and you're not feeling any benefit, we'll give you a little bit more next time, right? So I prefer to err, if there's going to be an err, on the dose of too low than too high. And that gets rid of this whole fear that, oh my gosh, I can't take it out, so if I have side effects, I'll be stuck with them. Yeah, that's true. So don't get too much. So 1 milligram per kilogram. So are pellets the best? No, of course not, but they are an option, and I just want to encourage people to think this is still an option in your toolbox. So if I'm a well-educated menopause provider, I believe I should be able to offer all the options, and all the options includes pellets, and so I think menopause providers, before they throw it out altogether and just say, it's bad, it's terrible, reflect on that is exactly what we said about estradiol some time ago before we got more educated. So no judgment, but I've said lots of things were bad and wrong, and then I learned and said, whoops, I'm sorry, I learned more. So I hope it's in that category that we can learn more about pellets being an option for women who just don't want to do gel every day, or they cannot because they swim, or they're triathletes, or they're lifting weights all the time, or they just forget, or all the many reasons why that could be tricky. Putting gel on every single day for the rest of your life, that sounds horrible to me. So I love my pellet because once every 3 months I get a little tiny poke in my skin the size of a pencil lead, tiny little pellet the size of a piece of rice goes into the soft tissue of my bottom. I can't even feel it. I go running the next day. It's just not a big deal. And is it more expensive? Yes. a little bit more, but if you think about it last 3 months and you're spending $60 a month on your cream and your time has any value, to me, it was an upside. To another person, it might not be. But I think every woman should have the ability to review all of the options and then make an educated decision. And frankly, the way some providers still talk about testosterone pellets sounds an awful lot like the way we used to talk about estrogen 5 or 10 years ago. So just some food for thought. If you like this episode, please don't forget to subscribe, share it with your friends. Please watch that Rachel Rubin episode with Peter Attia. It was amazing. Such good information, and I can't wait to see you next week.